Thank you so much. And I just want to thank the center for having me here, and definitely Lisa. Lisa and I met in North Carolina, and that is where I am from. And I wanted to thank you personally for having the exact same weather that I left here in Virginia. And how's the sound? Are we good? Because all I hear is I sound like a professional 12-year-old. So hopefully you guys will be okay. I hate having people read my bio because I think you'll learn enough about me through my presentation. I will tell you that I am from North Carolina. I am in the Asheville area. Does anybody familiar with Asheville, North Carolina, in the mountains? I am the project director for the North Carolina Fetal Alcohol Prevention Program and Mother to Baby NC. And I am funded through some federal dollars that come into the state. They've shaved off a little piece for fetal alcohol spectrum disorder prevention. So I'm housed in the west in the mountains, but I actually cover the entire state of North Carolina. And so primarily I talk about prevention efforts. So when I deliver this information today, we will touch on a little bit about how it is going to present in individuals, meaning fetal alcohol spectrum disorders. But I'm not going to go into extensive information about interventions because that is a whole nother 2-hour presentation. And what you're getting today is definitely a down and dirty. Okay? So, disclaimers that I may have. The hair that you see before you now will not be the hair that you see at the end of the 2-hour presentation. I am a little menopausal, so I run pretty hot. Do not be alarmed if I turn red and my hair goes like this. Okay, don't be alarmed, except this lovely lady has volunteered to assist me if I do fall out, right? Because she was the first one to sit close to me this morning. What else do we have? I'm pretty sure I picked the good pair of tights and underwear, so I shouldn't have any malfunctioning going on. And as you can tell, I am pretty open and deliberate as it is. And the reason for that, and to be honest, that is not out of any disrespect for families or individuals that may be dealing with fetal alcohol spectrum disorders, but I'm going to be honest with you, this is not a happy topic. It's downright depressing. And so I do try to deliver the information with a little bit of sense of humor and lightheartedness, but I will guarantee you by the end of today or this morning, you will probably have more questions than you will answers. And that's the nature of the beast when we deal with fetal alcohol spectrum disorders. I am hearing that when I turn my head this way, Mr. IT guy, that it's louder. I'm going to scoot this just a little. Put it on my necklace. Better? Better. Okay. You guys can see I'm loaded here, so we'll see how I do. All right. You guys know who I am, a little bit about me. By a show of hands, I'd kind of like to get an idea of who is here with me today. How many of you actually are substance abuse professionals by raising your hand? Okay, good majority. How many of you are in the field of social work and possibly work with women of childbearing age? Okay. Anybody work with children, families? Okay. How about educators? Do we have anybody from the school system? Yay. I mean, I'm happy that everybody else is here. But, you know, when you work for the school system, they don't let them out much. Okay. So it's really good, and I'm glad that you're here, even with the delay and so forth. Do I have any nurses? Super, super, super. Public health? Private practice? Hospital, a little bit of everything? Okay. All right. Any psychologist, therapist? Great. Feel free to correct me at any time if I don't say anything the proper way. And how about anybody involved with juvenile justice, criminal justice, anything like that? Okay, great. Have I missed anyone? Okay, any disciplines? I'll do my very best to try to cater this information to you as best I can. I did send handouts, and you guys are going to get an electronic copy of the PowerPoint presentation. And on that PowerPoint presentation, there will be links that you can click on for additional information. And I kind of like giving the PowerPoint presentation out to you after the fact, because if there are any questions that come up that I didn't address, I can possibly put them in the PowerPoint or attach it with it. So, ladies, if I could ask one of you, if questions come up, maybe if we could jot them down, I may be able to address them this morning, depending upon our time. If not, I'll make sure that I do answer the questions. And if I don't have the answer to the questions, then I will find that answer for you to the best of my ability and make sure that you do have it. Next to the sign-in table, there were a variety of handouts, so I just picked some generic ones. All of these that were there, you can access online and they are free of charge. So don't feel that you have to have money to order brochures to be able to hand out to clientele as it relates to fetal alcohol spectrum disorders. Okay? So, another by showing of hands. How many have heard of fetal alcohol syndrome? Raise your hand. Most everybody in the room. How many of you have heard of fetal alcohol spectrum disorders? Not so much. Fetal alcohol effects? A little bit more. Fetal alcohol effects has now been replaced by fetal alcohol spectrum disorders. And you're going to learn a little bit more about the spectrum of this disorder. But before we do that, I want to take you through a little icebreaker activity. No, I am not going to make you get up, walk around, and move. If it was a smaller group, yes, but because of our size, not today. But what I want you to do is when I read the statement on the screen, I want you just to answer to yourself. Yes, no, I'm not sure. And all of these slides are going to be helping us kind of guide us as far as our objectives for the day. We're going to kind of touch on stuff, okay? I keep saying the day. Do not panic. I'm not going to keep you here that long. We really only have 2 hours, and hopefully I'll be able to get all that in. So we're going to keep going. If you cannot see the screen, I think we did the best that we could as far as, the sun is kind of reflecting off the snow, so it may be a little bit of a glare. If you need to move, bring your chairs closer, do whatever you need to do to be able to view the screen better. So let's go ahead and get started. So again, you're going to be answering, I agree, I disagree, or I'm unsure. So these are just statements surrounding the issues surrounding fetal alcohol spectrum disorders. It is safe to drink a glass of wine during pregnancy. You do not out yourself. You do not have to say yes, no out loud. You're just answering. It's safe to drink a glass of wine during pregnancy. Illicit drug use during pregnancy causes more harm than alcohol use. Media promotes alcohol misuse in our society and often targets youth and women. Women know that they shouldn't drink alcohol during pregnancy. I'm going to hang on that one a minute. Women know that they shouldn't drink alcohol during pregnancy. You can tell which of these women struggle with alcohol addiction by looking at them. Women who consume alcohol during pregnancy should be criminally prosecuted. This is a tough one, and if we were doing an ethics class, which I do an ethics class surrounding alcohol use during pregnancy, I've seen people start wanting to pull hair and sling snot over topics like this. Very, very interesting. Fetal alcohol spectrum disorders is understood and recognized in our society as a brain-based disability. Men are responsible for fetal alcohol spectrum disorders. Individuals who have an FASD are easy to identify. And I will go ahead and tell you, they are not easy to identify. And all of, what was that? You're right under that speaker. Thank you. I almost peed a little. Did you? That scared me. Whew. Okay. Just keep me over here. Okay. All of these individuals have an FASD, and we're going to really look at that much more closely. Fetal alcohol spectrum disorders is 100% preventable. Okay? So all those things we're going to address this morning. All right? So we're going to move into the terminology, the alphabet soup. We're going to talk a little bit about the diagnostic criteria, and then also we're going to look at a little bit of statistics. So, what is an FASD? FASD, fetal alcohol spectrum disorders, is the range of effects that can occur if a woman consumes alcohol during pregnancy. So I have this umbrella on the screen because this is an umbrella term that we use to describe this range of effects. under the umbrella, we have the variety of ways that this can present in an individual. The most severe is fetal alcohol syndrome. Then there's PFAS, partial fetal alcohol syndrome. Then there's ARBD, alcohol-related birth defects. And then there is ARND, alcohol-related neurodevelopmental disorder. That does not roll off the tongue well. Okay? So what I hope that you will glean today is that the range in which it can affect, we have to take this terminology and put this in perspective when we're talking about the individuals that we work with or are taking care of, because they could be presenting on this spectrum. FASD is not a diagnosis, it's just the term. A diagnosis would be a fetal alcohol syndrome, and we'll look at that in just a second. But before we move on into the terminology, I want to introduce my babies. They flew with me. Basically, I had one outfit, a pair of clean drawers, my boots, and a nightie, and the babies, and I did get pulled in security yesterday. They opened up the bag. They were very interested in why I had babies and beer and brains and a placenta flying with me from North Carolina. But this is Gracie. And I'm going to pass Gracie around and let you look at her. I want you to examine physically what she looks like and any other type of characteristics that you might see. I know you're hitting the yogurt right there, so I'm going to start Gracie over here. And then we have Bradley. Now, Bradley is a baby think it over, and he is packing batteries. And baby think it over, they are programmed to cry. He is not programmed. He's not going to start crying. But he's heavy because I lost the key and the batteries are still inside, and he feels like he's got a loaded diaper, okay? So I'm going to start him around. And so what I want you to do is as you look at the two, I want you to make note of any similarities or differences that you may see, and then we will revisit them. So again, with fetal alcohol spectrum disorders, we're talking about individuals that are affected across the lifespan. There is no cure for an FASD, and as we talk about interventions, some of the interventions are difficult, and families have a hard time providing care and accessing services. So again, keep in mind this is a lifelong effect, and these delays, we can see them as early, for some, at birth, but a majority of them we see as they progress through the school system and then on into their adult life. So that can be delayed development, hyperactivity, learning disabilities, a lot of executive functioning delays and challenges, and then a lot of this will present, and we'll talk more about this, as behavioral problems. Okay? So here's the terminology. PFAS, partial fetal alcohol syndrome. So what that means is that an individual may have some of the characteristics of fetal alcohol syndrome, but not all, so therefore they don't get the diagnosis of FAS. Alcohol-related birth defects. Now let's say, well, and I'll go ahead and share with you, with Gracie. Gracie has fetal alcohol syndrome. She's presenting with the facial characteristics that we're going to look at in just a minute. So if Gracie is born at a hospital, those that are providing care for her are going to go, okay, I think that there's something going on, even if we didn't necessarily have a confirmed diagnosis, or a confirmed prenatal alcohol use by the mother. So we kind of know what's happening. With alcohol-related birth defects, that would be the same thing, because they may be born with actual challenges and problems that involve the heart, the kidneys, bones, hearing, and vision. And also we see a lot of children with FAS or alcohol-related birth defects, they have seizures as well, okay? So that we kind of know. Then, this is the big one, alcohol-related neurodevelopmental disorder. They don't have any of the facial characteristics at all, and that's Bradley. We don't have a confirmed maternal alcohol use, we don't know. And a lot of these children are showing up in our foster and adoptive system, so those records are closed, or we can't access them, or maybe we just have hearsay that a family member says, oh yeah, she drank like a fit. Well, that's not a confirmed use of alcohol. And what happens is they don't have the facial characteristics, but they have the brain damage. And that's where a majority of the individuals are. For every one Gracie, for every one fetal alcohol syndrome, the severest end of the spectrum, there are 10 Bradleys out there that are not diagnosed. Yes, sir?
delivery room nurses and doctors are resistant to labeling FASD?
You know, I don't know if they're necessarily resistant to labeling. Right, may of something else, or they just don't know because depending upon the situation surrounding the birth, if the woman has been in treatment, maybe we have an idea of whether she was using alcohol or there was poly drug use going on, so maybe they have a little bit of information coming in so they're ready and they're expecting. But what can happen is, even if the mother was using, and we're going to find this out later as we go on today, depending upon when she used, that child may or may not have facial characteristics but still have the cognitive impairments, and that's not going to show up at birth, so they may not always know. I did do a little research, so this is a great segue. Yeah, I knew you came up early and asked me a question. I knew you were going to be the one. I knew it right up, and that's okay. I did a little research with Virginia, on Virginia, and you guys do have legislation in place, and the original legislation was, I believe, 2006, 2008, that said that if an infant presents in the first 7 days of birth with symptoms of fetal alcohol syndrome, it can be used as evidence for child abuse, and the parent can be prosecuted. And then in 2012, that was revamped, and this is what gets me, is that they went from it was 7 days in the first 7 days. And then they linked in that to 6 weeks, like within 6 weeks we're going to know. Because, yeah, if it's presenting like Gracie or they have alcohol-related birth defects, we might. But what about the Bradleys? Okay, so after that 6-week period, then what? So in your state, you know, healthcare providers can report that, and then they can pursue that for child abuse, which I find that very interesting. In North Carolina, we do not have such legislation. In the South, I know that South Carolina does criminally prosecute women if found to use alcohol during pregnancy because they use the delivery system, being the placenta umbilical cord, so they can be charged criminally. I would be curious to see in Virginia how these laws have impacted access to prenatal care. Because if women know this, they may be less likely to access care, and they may not be ready to enter treatment or don't know about treatment. You know, there could be a whole paradigm going on. So I'd be curious about that. So if you want more information about your own laws in your state, I'm going to pass this around. This is pulled from one of your resources, and actually I can just tell you about it. You will be able to go to the Center for Excellence, the FASD Center for Excellence, it's a SAMHSA website, Substance Abuse Mental Health Service Administration, and it's the FASD site, and it has for every state in the United States any legislation that has been passed related to alcohol use during pregnancy. So you do have that, and I had printed out Virginia legislation related to substance use. So if you really want to look at that, you can come up afterwards, and you're more than welcome to, but you'll be able to access that through the resources that I've given you. So that's a really interesting question. And then also, you know, for those care providers, do they want to report? Well, by law, they're required to report child abuse. We all are, whether we're in the healthcare profession or not. So I think for some individuals, to answer your question, maybe they don't know all the information, they're unsure, and then maybe they're worried about what will happen in the outcome for the child and for the family. So I can't answer that specifically. Anybody in the field of social work or working with, we call it in North Carolina, Department of Social Services, anybody want to take a stab at that answer, or for an answer? Oh, y'all didn't know it was going to be interactive, right? Okay. But that's a good question. What do you think?
Well, I don't know, but I would think, maybe they have Down syndrome and just pass over it.
Right. They could. And do know that Down syndrome and other conditions, they're going to present very differently than fetal alcohol spectrum disorders. And we'll talk specifically about how that might present at birth. Okay? All right. So, here we are. So those of you that have seen Gracie and you're about to see Gracie, for fetal alcohol syndrome, this is a medical diagnosis. Okay. There is we call it is it IC9, what do you call that for diagnosing? IC9, now 10's getting ready to come out. There is a diagnosis for that. Fetal alcohol syndrome, or FASD, just made it into the DSM-5, but it's in the appendix. If you want specifics about that, you can contact me and I can make sure you get that information of where it is located. But being in the appendix, they give the example of prenatal alcohol exposure. And so there's a code attached to it. So what that does is it places fetal alcohol spectrum disorders on the behavioral side. Some parents are happy with that. Some parents are not happy with that. Parents being parents of children with an FASD, because some parents would like it to be on the developmental disability side, the DD side. So that can be a little bit tough depending upon what the needs of the family are. As of right now, all those of us in the field do know that it presents on both sides, depending upon when that damage was done to the brain. So right now, there are billing opportunities on the behavioral health side, on as far as mental health issues, not so much on the DD side, okay? Unless they have a dual diagnosis. Can you see how this gets very complicated very quickly, okay? So, with this being a diagnosis, in order to get the diagnosis, there is a very, very strict criteria that has to be followed, and that has been set forth by the Center for Disease Control and Prevention. And it is usually done by a developmental pediatrician or a clinical geneticist. I actually work or am housed at the only pediatric multidisciplinary FASD clinic in the state of North Carolina that's held in the West at Fullerton Genetics. But other genetic centers can do the diagnosing if the geneticists have been trained. I could not find out for Virginia how many of your geneticists in the state are trained. I'm actually still researching that for you. I made a lot of calls and I'm trying to find out, and I will continue to do so, and I will share that with Lisa and Darlene and the folks here at the center to make sure you get that information. So if I'm having a hard time finding out, can you imagine what the families are struggling with? So, and this isn't, and I'm not picking on Virginia because we have the same issue in North Carolina and a lot of other neighboring states. This just isn't on people's radar at this point, okay? So, what has to be present in order to get the diagnosis? Well, there has to be evidence of growth retardation or restriction. That could be prenatal or postnatal, or both. Characteristics of the facial anomalies, and then central nervous system impairment. And when I talk about the facial anomalies, I'm talking specifically about these three things. So these three things have to be present. There needs to be evidence of smaller eye opening. So we take a measurement from point A to point B, and interestingly enough, it's the eye opening that's smaller, but it gives the illusion that their eyes are really, really big. And it actually even gives the illusion that the bridge of the nose is much broader. So that's the first physical characteristic that has to be present. The second one is we have to have a very smooth or flat philtrum. Everybody place their finger here. This is your philtrum, okay? Please, at break, do not go to the bathroom and try to self-diagnose and then come out to me and ask me if you have an FASD. I do not diagnose, but I guarantee there will be people going, well, my mama, you know, she drank, and don't be making phone calls to your mom and throwing her under the bus, okay? Because it's kind of a perfect storm to have this diagnosis. But you do have that flat or smooth philtrum and a very thin upper lip, okay? Those three things have to be present. There's other markers that we do see, but as far as involved in the diagnosis, these three things have to be present, plus the growth retardation or restriction, plus the central nervous system impairments. So that's why it's hard to get this diagnosis, and really why there's one Gracie, but there's 10 on the spectrum, okay? So when we do this, and here's the specifics, the growth restriction at or below the 10th percentile, not due to poor nutrition or some type of illness or other disease, those three characteristics, the facial anomalies that I was talking about, and then central nervous system impairment, that could be structural, neurological, and functional, presenting that way. Originally, several years ago, we had to have documentation of prenatal alcohol use to get the diagnosis of fetal alcohol syndrome. They do not require that anymore because of so many individuals being in the foster and adoptive system, because we just didn't have that information. But we had kids coming in, they're presenting with everyone, you know, the characteristics. So CDC has kind of relaxed that just a bit. Okay? Any questions about this thus far? Okay. All right, just to show and to share with you, if you want to diagnose your neighbor or try to, just for fun, this is called a lip philtrum guide. And so what we do, Lisa, you want to come up? Poor Lisa. So what would happen is, if it was a birth family, we would do this on the mom, the dad, and the child to make everybody inclusive in the visit. And even if it was an adoptive or foster family, we would do the same thing. But what happens is we would actually, and we have a Caucasian and then African American guide. They're working on Asian and Native American and other diversities as well, because our genetics and our heritage also dictates a lot of this. But what would happen is they would hold it up to the individual's face. Oh, she is just like Angelina Jolie all the way. Don't smile. Don't smile. Just very flat. You would want a very flat affect, very flat. Because when we smile, our philtrum smooths out. And so what would happen is, I would definitely say she is like a 1. So if you were a 4 or a 5, that's suggestive of fetal alcohol syndrome. But a 3 or below is considered, I'm going to say typical. I hate the word normal because I don't think there is anything that is normal. Okay, so 3 or below would be typical. So thank you very much. So you guys are welcome to pass these along. Now, as people age, and especially for men, well, for some of us in menopause, we have mustaches and hair, facial hair, and so that can kind of change also and make it a little bit more difficult to diagnose, especially if we're looking at individuals that are in adolescence and older. Okay, so this was just one of the tools that I could bring with me flying up here to show you that we do use, so you're welcome to pass that around. Okay, so when we are diagnosing at the clinic, and when I say we, I'm saying collectively, I do not do that at all. I'm not a geneticist, I'm not an embryologist, I'm a prevention educator, and I'm just kind of cute from an angle, and they let me out and go and do all this. So I am not an expert in the diagnosing field. But I will say that they actually do look at racial background, and they also look at genetics, which is the beauty of having genetic centers doing this, because there are some disorders like Williams syndrome that kind of mimic fetal alcohol syndrome. So it would be great to rule out any other genetic disorders. Okay. So most clinics would do a comprehensive history. They're going to try to pull any and all medical records from birth, and if we have access to prenatal records, we would ask for that. And they do a lot of interviewing and gathering information even before the appointment occurs. Then, if there's been any standardized testing on the child or individual, they would ask for those results. And we would strongly encourage, if they've not been seen by a neuropsychologist and have a neuropsych eval, we would encourage that. Because a neuropsych eval really helps kind of pull the pieces together between the behavior that's presenting and possibly the brain damage that's occurring. And that can help round out a review for the individual and would give us a better picture of what's going on, because a lot of the interventions that we would recommend to families involve helping manage behavior, but we have to make sure that the families understand that this is a brain-based disability. And sometimes we don't always connect those two, brain and behavior, but by the end of this morning, hopefully you will. And then, of course, there would be a physical examination, either by the geneticist or the developmental pediatricians. Most pediatricians are probably trained to recognize the Gracies, not on the spectrum. However, there is a wonderful toolkit that just came out, and you have a link to this. You will have a link to this on your PowerPoint. And that is by the American Academy of Pediatrics, and it's the FASD toolkit. You can Google it. You can Google FASD Pediatric Toolkit, and it's going to come up. It's an online resource. If you know anyone that works in early intervention or with young children, it is an excellent, excellent tool, not just for pediatricians, but for everyone. Has a beautiful algorithm that pediatricians can use. If the child presents with this, you can go to here. If this is here, then you do this. It's step by step, and we're really lucky in North Carolina because one of the authors is a developmental pediatrician in our state, and she's doing diagnosing on her own in the middle part of the state. But that's a great resource for you as well. And then the big one, the behavioral observations. Okay, what are we hearing from the friends, the family, the caregivers, the early childhood education staff that's working with the kid, or the teachers? We look at all of that, okay, to help come up with a type of diagnosis. I didn't list what an individual would walk away with at our center because it's not, applicable for you guys. But know, again, that getting the diagnosis for FAS is very difficult. But they may come away with something like static encephalopathy, which is unchanging brain, or one of the neurodevelopmental disorders. Okay. Statistically, what are we looking at? Well, this is the tough part because none of our states in the United States really have a great prevalence system because so few present like Gracie, so there's not a box to really check at birth. So many of them don't present until between ages 4 and 6 or even beyond age 6. So capturing this data has been very difficult. So there's specific studies that are going on in the United States and all over the world actually that are trying to capture prevalence, and then they kind of base everything off of those specific studies. So the Center for Disease Control back in 2009, and as of right now they are sticking to these numbers, but they are doing new studies. The CDC feels that there's anywhere from 0.5 to 2 cases of fetal alcohol syndrome, okay, of the Gracies of the world, okay, per 1,000 births. So that to me is just the tip of the iceberg. So that's just looking at FAS. I can say that their projections for taking care of Gracie for her lifetime will run about $2.5 million just for Gracie. Okay. Then there's NOFAS, the National Organization for Fetal Alcohol Syndrome, and they say, yep, CDC, we got that, we believe you, okay. But what we want to look at is the whole picture. Not only the tip of the iceberg, but what's under the water that we're not seeing. So they are saying for the entire spectrum, that's FAS and how it presents on the spectrum, that really it is as prevalent as 40,000 infants each year in the United States are born on the spectrum. That's about 1 in 100 births. And those numbers are actually higher than Down syndrome, spina bifida, and muscular dystrophy combined. Okay, we're not discounting those disorders because those are all very serious. We're just saying that individuals born on this spectrum, that it is very, very high, and we're just missing it. And there's a gentleman by the name of Kenneth Jones, and I actually got to hear him speak in the fall, and he was one of the doctors that actually came up with fetal alcohol syndrome. He was one of the first ones to truly make that diagnosis and coin that diagnosis, FAS. And we just celebrated 40 years of research for fetal alcohol syndrome. And it's taken a while, and we haven't come as far as we had hoped, and he definitely was able to speak to that. And so he's the one that says for every one child with FAS, he feels, because he's still actively in the field, that there are 10 with an FASD. So that's where that came from Dr. Kenneth Jones. When you have the PowerPoint presentation, you can click on this link, and it'll take you to a YouTube link by Dr. Philip May. Dr. May is actually, housed in North Carolina now, but he has done studies all over the world, and he will talk to you and tell you about what he feels the prevalence really is for this disorder, and it's even more so than what Dr. Jones is projecting. Right now, for us in North Carolina, he is doing a study of first graders in an undisclosed school in North Carolina. So I'm hoping in 3 to 5 years, I'll actually have some viable numbers that I can really give to folks in my state. I do want to point out that NOFAS is located in Georgetown. So DC, what did we say? You told me, Lisa, 2.5 hours from here. So you do have a very close resource from here to get more information if you need it. Any questions about this statistically? Well, what does that look like for Virginia? Here's the tough part. Again, with no box to check, it's a guesstimate. So there is a gentleman by the name of Dr. Larry Bird, not basketball Bird, but Dr. Bird, and he has an online clinic, and this is his link to his clinic. And what he does is he takes the total population of a state, the total number of live births, and then he puts it into a little formula. And the formula that he uses, and you can tweak it. You can put in higher numbers or lower numbers. I erred on the low side. I went with what CDC said, that there are 2 cases per 1,000 births. So I went low. I lowballed it. And I based it on 50% of the live births, 50% of the total live births that you had for your state in Virginia were exposed to alcohol. Does that make sense? So I only just did half. With that, what happens, it spits this out, and it says that there's an estimated 822 cases each year in your state of children born on the spectrum, based upon 50% exposure. So you can tweak those numbers all you want. If you go with what Kenneth Jones says, or even what Philip May says, and move these numbers up, you're going to get a larger number. So I guess it depends on who you're advocating. I almost said the L word. Who you're advocating. If you're trying to advocate for laws to be changed, okay, you're going to jack those numbers up. But I did err on the low side, okay? And this is a guesstimate. Any questions about that? Okay. So, why are we talking about this? Well, we're talking about this because of alcohol. And it is all alcohol. I don't care if it's beer, wine, spritzers, coolers, hard lemonade, hard cider, shooters, Jello shots sucked out of the belly button of a good-looking man, whip-a-haul, alcohol caffeinated drinks, snow bars, or Alka-Pops. It is all alcohol. Those that laughed have seen Jello shots sucked out of somebody's belly button, okay? I'm just outing you right now in the group, okay? Is there anything listed here that you don't know what it is? And do not be afraid to ask. Yes? Whip-a-haul is alcohol-infused whipped cream. So with the surge of after-dinner drinks, dessert drinks, they've come out with alcohol-infused whipped cream, which you can order online, and definitely if you work through a restaurant distributor, you have access to it. Unfortunately, our youth have found ways to get access to it. So not only are they using the dispensers for whippets, the nitrous oxide, which kills brain cells like that, they're also getting a little bonus of alcohol in their whipped cream, okay? But where we see this is for women who go out and have a girls' night out. They may have a drink before dinner, wine with dinner, but they pass on dessert because they're watching their figure, but then they decide for an after-dinner drink. And sometimes they can request for it to be infused with alcohol, the whipped cream. So what happens is women specifically, because that's who we're really wanting to target today, is women of childbearing age, they oftentimes are engaging in binge drinking behavior and they don't even realize that they are. And that's an issue in the United States. What else? Yes, ma'am. Snow bars, alcohol-infused popsicles. Okay, they primarily are up north, but you can order them online, and the recipes are online, so we have youth and women that are making them. And listen, if you do not struggle with substance abuse, if you are of childbearing age and actively preventing a pregnancy, and you don't drink and drive, and you're of legal drinking age, whether you be male or female, I'm not against alcohol consumption in moderation. So I'm not the bad person saying no, but that's not really how society is shaped. And people don't understand the dangers related to alcohol use. So snow bars, definitely alcohol infused. Yes, ma'am. Jello shots, that would be your basic Jello, and instead of using water, you use vodka or any kind of clear liquor. Yes, and they put them in little plastic cups that maybe pills would come in at a hospital, and so they're not even plastic. They're, you squish them and suck it right up, or suck it off the bar, or out of a belly button. Just depends on what's happening that night. Okay. So, Alka-Pops. Do you guys know what Alka-Pops are? Okay. Alka-Pops are basically any type of alcoholic beverage that has fruit juice in it, sugar, and fruit. That is going to be, and you guys may have to familiarize, and boy, Lisa, that was supposed to, I wanted to go and see what was available in your grocery stores. Can you buy wine and wine coolers in your grocery stores in Virginia? Okay. Do you have liquor stores separate? Are they ABC? Oh, okay, so we're all kind of on the same boat there. That's good for North Carolina. Well, in North Carolina, there's a big movement by the Preventing Underage Drinking Initiative to move Alka-Pops out of convenience stores and grocery stores and move them into liquor stores so they're not as accessible to our youth. Because we know that the alcohol industry, and this answers one of your pictures at the beginning of your icebreaker, that media and the alcohol industry does try to manipulate alcohol use for our youth and women. I'll give you a good example. They usually come out in the spring and summer. You can still get them now, but they're little silver pouches, and they're marketing them to women and kids, and they put them in the fruit and vegetable section. They're hanging on trees. I guess they're trying to pass them off as fruit because they have fruit in them. Or they're on the end cap of an aisle, and they're basically 5% alcohol, but they're rum runners, electric lemonade, frozen margaritas, and they have alcohol in them. But the key, is the silver pouches. Anyone have kids here in this room? Anybody know what Capri Suns are? Okay. Most kids today, they've been raised on the silver pouches. So the alcohol industry said, ha-ha, we'll put alcohol in the silver pouches, so it'll be an easier transition for kids. They'll be more likely to move into alcohol use because they're familiar. They know how to hold the pouch. They know how to put the straw in the pouch. They know how to dispose of the pouch. It's kind of like the candy cigarettes of my day. Okay, so it's a gateway. So we as parents, care providers, substance abuse professionals, prevention educators, whatever your role may be, we have to make sure we stay one step ahead because the alcohol industry is. They're reaching our kids before we reach our kids. I will tell you that there was something that came out yesterday. Where did I put it? Kids are taking Jolly Ranchers, cough syrup with codeine, and sodas and mixing it. And they're getting alcohol poisoning and codeine poisoning, and there are kids that are dying from it. Some other trends, just to let you know, we won't stay on this too long because I could do a whole thing on trends with youth. And I have 2 teenage boys, 18 and 13, so I try to stay up on this as much as I can. One thing they're also doing in the middle school age range, they're infusing gummy bears, gummy bites with clear liquor like vodka and repackaging them and eating them. In the high school range, what we're seeing is they're taking tampons, a large tampon, they're soaking them with vodka and inserting them up their vagina or their rectum. That's both male and female. That's very dangerous because the alcohol crosses straight into the bloodstream. There is no digestive tract to break it down, and it causes alcohol poisoning. And what happens is we're having kids that are presenting with erratic behavior, but there's nothing on their breath until we get them into the emergency room and we see, in fact, that that's happening. Then there's also the hand sanitizers, okay? They were cooking that down. Now they're just shooting it straight. They will drop clear liquor directly into their eye, okay? Then there are also definitely the NyQuil and the cough medicines and those kinds of things. And then if we step over into drug-related behavior, they're doing Skittle parties is one way that they call it, where they take prescription drugs, put them in a bowl, mix them up. There's alcohol offered at parties, and then they just take a handful of pills. They don't know what they've got, so forth. So there's a lot of things. So what I would do is if you work with youth or you have children, I would get online and Google, how do I get wrecked without my mom knowing? Or anything that is the lingo that your child in your region does, and you will be surprised all the things that are listed for them to do. Yes, sir.
Back in Maryland where I started, we had kids shooting up Jack Daniels with needles.
Mm-hmm.
I haven't seen any down here.
I haven't seen that down in the South so much, but yeah, absolutely. So definitely need to be aware of that. And again, the consumption that we are seeing in our youth and our women is just astronomical. Where we're seeing binge drinking and some other things kind of drop off for men, it's rising for women, and we'll look at those numbers in just a second. Now, I do want to ask you, when you see this particular picture of a red wine, what message do you hear in your head when you see that? One glass is good, heart healthy, antioxidants, yes. But unfortunately, it's not tagged with except during pregnancy, okay? So we have a lot of women of childbearing age who may get pregnant, and they still are thinking that message, a glass of red wine is okay while I'm pregnant. It's not going to harm the development of the baby. Now, I'm going to tell you right now, I can't stand here and say one glass of wine is going to cause an FASD. But I can tell you with confidence that I feel that one binge drinking session can cause an FASD. Okay? But if you're working with women of childbearing age, and if you have a woman who's pregnant and comes to you and she says, God, I'm so stressed and I just really want to have a glass of wine. Is it okay, doc, for me to have a glass of wine? There are going to be healthcare providers, OBGYNs, that are going to say, a glass of wine is okay. But in that doc's mind, they may be thinking 5-ounce glass of wine. That's a standard serving, 5 ounces of wine. To that woman, she may be thinking, you know, a solo cup underneath a thing of box wine in a refrigerator on free pour. Okay? So we have to understand that our perception of what a standard drink is and what a woman's standard serving is can be very, very different. If you are doing interviewing with women that are of childbearing age or and/or pregnant, you do not have to have a fancy drink set. I brought my beer out of my set. I have a very fancy set. This is a standard serving of beer, 12 ounces. I bet if any of us went to our favorite restaurant and asked for a beer, it's going to come out like this. At my favorite Mexican restaurant in Asheville, oh yeah, it's huge. And so we are under a misperception of what a standard serving is. So we have to make sure that those that we work with and our youth and our women know this. Okay? Yes, we're supersized, not only with food, but also with beverage as well. So again, making sure we know our standard servings. So for beer or wine coolers, 12 ounces is a standard serving. For wine, 5 ounces. For liquor is 1.5 ounces or a shot glass. Okay? And again, you can use this table, but here's what I ask you to get. If you are working directly with women, get a true solo cup, because not all red cups are created equal. Get a solo cup. And you could actually go to a woman, Lisa, I'm just going to pick on you, pretend you drink. Okay. And pick whatever it is you like to drink. So you consume alcohol.
Okay.
Okay. And when you consume alcohol, what do you drink, Lisa?
Vodka sodas.
Vodka sodas, all right. So when you drink your vodka soda, can you show me, by pointing in this cup on these lines, where you pour your vodka to?
Okay. Well, above the bottom line.
Above the bottom line. So right about here.
Okay.
Okay, great. And do you put ice in it?
Mm-hmm.
Okay, and then where do you pour your mixer up to? Does it have a mixer with it that you prefer?
Soda water. I mean, I might
Just
go
soda water.
Yeah.
Okay, very good. All right, well, thank you, Lisa.
Okay.
So the first thing, you automatically assume all women drink, and you try to remove any type of shame or blame or guilt. Just assume that everyone drinks. But just to let you know that just above the line right here would be 1.5 ounces of hard liquor. 5 ounces of wine is here. 12 ounces of beer is here. So when we look at this, so to the bottom line is 1 ounce of liquor, 5 ounces, 12 ounces, and then most people, when they have beer, they're going to fill it all the way to the top, tip it, and have it just as much as they can, and they're going to have a pint, 16 ounces. Okay? So this is the only tool that you really need, and it's easy to be able to ask the woman, can you show me, and ask them what they are drinking. And then you can go on to ask, how often are you drinking? Which leads us to talking about binge drinking. So with binge drinking, where's my beer? Can I see my beer? Thank you. For binge drinking, for a woman, 4 standard beers, 4 of these, 1, 2, 3, 4, is a binge drinking session. 4 shots, 4 5-ounce glasses of wine, okay? 1.9 ounce of gin in a martini, 4. That's the key. 4 standard drinks is a binge drinking session. But here's the kicker, the timeline of that consumption. We'll say, and you'll see in the literature, it'll say per an occasion. Now, I'm not talking birthday or New Year's Eve. I'm talking a length of time. What is the length of time per occasion is referring to? Does anybody know? How long? To drink those 4. It's 2 hours. For men, a binge drinking session is 5 standard drinks per 2-hour period. That's not even an entire sporting event. So again, we don't have all the knowledge that we need. So we have individuals out there that are over-consuming and they don't even know it, especially women of childbearing age. Okay, you with me? Keep that beer going around. There you go. All right. So, what does this look like as far as the scope of the issue and why we're concerned? I see it's about 5 till 10. We're going to go until just a little bit after 10. I'll give you a quick break, and we'll come right back, okay? But everybody good so far? Okay. All right. So this is a study that was done, and it was really combined data from 2006 all the way to 2011. And this was women, pregnant women of childbearing age that were asked these questions. And that age range here is reflected in ages 15 to 44. You have to look specifically at the data because some data will say 18 to 44. Okay? But this one is 15 to 44. So when asked about past month consumption of alcohol or past month use, 8.5 reported alcohol use throughout pregnancy. Throughout pregnancy. That's the key. Okay? 17.9% reported use in the first trimester, and then 6.6 reported binge drinking in the first trimester. The hard part is when in that first trimester were they drinking? Was that before they knew they were pregnant? Was it once they had known that they were pregnant? Okay? And when anyone answers that there's past month use, that places them in the category of a current user. So if you consumed in the past month, you're considered a current user. Okay? And then another study, kind of related, this was published in 2011, and this was asking about the intention of pregnancy. 49% of all the pregnancies in the United States from 2011 were unintended, unplanned. So 50% of our pregnancies are unplanned. There's a good chance that some of those pregnancies are alcohol-exposed pregnancies, and that's what we need to be concerned about. Okay? So another study, this was a combined study looking at youth. So it was a behavioral risk factor surveillance system and youth behavior survey done, and also of adult women. And this was about binge drinking. So again, what is binge drinking? How many drinks per 2-hour period? 4. Okay. 1 in 8 adult women admitted to binge drinking in the past month. 1 in 5 high school girls admitted to binge drinking in the past month. When we were asking them the amount of use of how often did they binge drink, on average, they were drinking 3 times a month. And then when they consumed, they were actually drinking 6 drinks per binge. So they were drinking over the standard 4 drinks when consuming. So we know that with binge drinking, it increases a woman's chance of not only an alcohol-exposed pregnancy, which is why we are here today, but it also increases the chances of breast cancer, heart disease, and sexually transmitted diseases in unintended pregnancy. Because we know that when women binge drink, they're less likely to prevent a pregnancy. Okay. Any questions about that thus far? Virginia, you have, and I don't know how I left off the date. I don't know. I'll correct that on the PowerPoint that goes out. This is combined data for 2007, 2008, and it's from the PRAMS data, the Pregnancy Risk Assessment Monitoring Surveillance System. What a mouthful. North Carolina has PRAMS data. Select states have. It's a program that's run through the Center for Disease Control, and they interview pregnant women. Okay? The survey sample is fairly small, but every state that has the PRAMS data does feel it's very reflective and indicative of the behaviors of the women across the state. The women that were interviewed, and here's what's interesting, is each state can kind of manipulate, not manipulate's not the right word, but well, they can manipulate the questions. I mean, they can put in whatever questions they want. Virginia didn't have a lot related to alcohol. Their main one was, did you consume alcohol during pregnancy? That's it. I want to hear, did you consume alcohol before pregnancy, during pregnancy? I'd like to know the specifics. Was it first trimester, second? You know, so North Carolina has teased out a little bit more information. There are those of you that could probably, in this room, work with your state agencies to kind of change those questions. There's probably a cost involved, paying to have more questions put on a survey, but it would be really great. Another one to find out was, is the pregnancy, was it intended? And another one would be, when did you find out you were pregnant? That's key. And the reason why I share that is because in North Carolina, over 60% of our women in our state did not know they were pregnant until they were between 5 and 9 weeks pregnant. So I'd like to see when the women in Virginia are figuring out they're pregnant. Because if there is alcohol exposure, boy, we would really like to know that. And these numbers are great because this also helps you when you're writing grants to bring money into your community, into your state. So, you're right on target with the national average as far as drinking during pregnancy. Because in Virginia, 8.6% of the women said that they drank alcohol during the pregnancy. The kicker is we're not sure when that was. Okay? Any questions thus far? We're good? Okay. So when we talk about alcohol in women, it is important to help women understand that the gender differences are quite dramatic, and that if a woman is paired with a partner who is also, especially if it is a male partner, who is struggling with substance use, they often tend to try to keep up with that partner in their drinking habits. And the way men and women metabolize alcohol is very differently. And for women, oftentimes it takes longer for us to metabolize the alcohol, so therefore it stays in our system longer. And if we happen to be pregnant, that exposure time for that developing embryo or fetus is much, much longer. So we need to make sure women understand how alcohol is broken down. Okay? And do know that if you're working with a woman who is in the disease process, just because she's pregnant, she's still going to struggle with craving and compulsion, loss of control, and she may continue to use even though she knows the consequences because she's struggling with addiction. So when we talk about FASD, we have to understand that we're talking about two different groups that could be consuming here. We could be talking about women consuming alcohol before they even know that they're pregnant. There is no intention to harm. They just are clueless. Then there may be the women that are struggling with addiction, and they don't know how to quit, they don't know how to access help, those types of things. So therefore, they're continuing to expose the developing embryo or baby. And then there are those that maybe do know, but they continue drinking because they get a message from their healthcare provider, from their family, and from media that it's okay to drink during pregnancy. So we've got a couple of groups going on when we're thinking about FASD. All right? So, again, looking at some contributing factors, and I just touched on the mixed messages, the lack of knowledge of alcohol, alcohol consumption, binge drinking, all these things. These are things that we need to work on, and that there's opportunities, many opportunities for something called SBIRT, and that's screening, brief intervention, referral to treatment, SBIRT. You're going to be hearing a lot of terminology about that. SBIRT going on in Virginia, most definitely, okay? And we're going to look at some resources for that. And then also birth control methods. When we give women birth control, North Carolina, Virginia, nobody pairs. We may say we don't pair the FASD message with it, and we're missing an opportunity there. What we do is we will often say, now, you know, if you were on prescription, if you take an antibiotic, that could change the effectiveness of your birth control, so you need to use a backup method. Or if you're sick and you're throwing up, that's going to change, blah, blah, blah. Nobody talks about the possibility that they could get pregnant, and if they're consuming alcohol, that it could cause an FASD. We have to work on changing those messages. So who should be screened? Well, basically all women of childbearing age, pregnant women, high-risk female drinkers, women that maybe have been in and out of treatment, maybe that struggled with alcohol addiction in their 20s, early 30s, nursing mothers. And this is something we do need to address. I was a lactation consultant for several years, and we used to tell nursing moms to have a nice, good dark beer. It would help their milk come in, blah, blah, blah. Well, now we know that probably wasn't the best advice to give because the brain continues developing until around what age? But 25 to 60, yeah, still developing. That's why we're so concerned about youth that consume alcohol, because the brain is still developing, and we know that alcohol changes the neural pathways of a developing brain. Here's the interesting thing. We're so worried about our youth drinking because of that development of the brain, but yet we're not giving any credence to the alcohol exposure in utero when the foundation is being built. Okay, we're missing something, and that's why you guys are here today. Okay, so nursing mothers, here's the down and dirty. If you have more questions about this, come up and I'll talk with you more at the break. If you were to consume 1 glass of wine, we would recommend you nurse the baby first. And since I'm a lactation consultant, I refer to my breast, I touch my breast. It makes people uncomfortable, but if you've been in childbirth education, and this is just what we do, this is how we roll, so please, hang with me. So we tell them to put the baby to the breast, nurse the baby, then consume your alcohol, your glass of wine, pump and dump. Then put the baby back on the breast. If you're going to have a binge drinking session or you're going to go out at night with the girls, we encourage you to pump and dump for 24 hours. Okay? But additional information, let me know. Okay? These are some direct sites, and if we had time, I was going to take you to this one. This is in Virginia, and this is tips for screening pregnant women. So this will be on your PowerPoint presentation, and you'll have access to that. And that will give you some ideas of ways to talk with women about alcohol consumption. Okay? Okay. So what does alcohol really do? Well, alcohol is, to me, one of the worst teratogens. And a teratogen is any agent, substance, or occurrence that can induce or cause abnormalities in the developing embryo or fetus. Okay, tobacco is a teratogen. Some prescription drugs are teratogens. And we know that there are women that are exposing themselves to other teratogens in addition to alcohol, which that's what comes into play. And we have kind of a perfect storm happening and why they may end up with a child that does present like Gracie, or maybe why a child presents like Bradley or somewhere on the spectrum. Yes, ma'am.
So that has more of an impact.
Say that again now.
The term actually means little monster.
Little monster, teratogen, little monster. Interesting. Interesting. Okay. So, prenatal alcohol exposure, we know, can contribute to premature birth, pre- and postnatal growth retardation or restriction, physical malformations. Sudden infant death syndrome now has been linked to alcohol consumption during pregnancy. And then, of course, there are the cognitive and behavioral problems. So, the overall message, if you don't take anything away from today, that during pregnancy there is no safe amount of alcohol, there is no known safe type of alcohol, and there is no safe time to drink. This is the statement of the Surgeon General. No matter what study comes out, and there are going to be studies that are going to say it's okay to drink. Okay, are they reputable? I don't know. But this is what the Surgeon General says. Because of all those other factors that we just talked about, genetics, other environmental teratogens, nutrition, maternal age, we can't say, Tina, you have at it, drink all you want. But you ladies, you better not touch a thing. You can't have a public health message that is like that. So that's why we have the standard message by the Surgeon General. Okay? So any woman who is pregnant or could become pregnant should not consume alcohol, or they need to at least actively prevent a pregnancy. Okay? And out of all the substances, including cocaine, heroin, and marijuana, we feel that alcohol by far produces the most terrible, the worst neurobehavioral effects in the developing fetus. This is a study that was done in 1996 by the Institute of Medicine, and it was delivered to Congress. That study still stands today. Now, you're asking in your mind, what about prescription drugs, opiate use, methamphetamines? Okay, we're still on the cusp of trying to see how all that shakes out. Are we seeing a lot of neonatal abstinence syndrome, okay, where we have babies that are actually born addicted and having to be on methadone or some form of treatment because of that addiction? Yes, but we're seeing that at the get-go. It's too soon for us to be able to tell what the neurological and behavioral impacts are going to be. But I will say that chances are when women are, if they're poly drug users, chances are they're not drinking milk and juice with their drug of choice. They're probably consuming alcohol. And if they can't get access to their drug of choice, they may turn to alcohol because technically it's legal to drink alcohol when you're pregnant. I mean, there's not going to be anybody at the ABC store that's going to regulate that. Do we have signage? Yes, Virginia, the state of Virginia has signage. That's awesome. But if a woman is pregnant and she goes to a bar, that server probably by law has to serve her unless there is actual signage posted in that bar saying that they can't. And, God, who do we know who's pregnant? I look pregnant and my kids are 18 and 13. So it's hard to gauge. So servers are not going to be the ones that police that. Okay? All right. So timing is everything. This is a plug to, this is me. And if you need to find me, this is an 800 number that will get to me, and then you can have my cards, and you'll be getting the PowerPoint presentation. We have something called a pregnancy exposure risk line in North Carolina. It's staffed by genetic counselors Monday through Friday, 9 to 4. And a pregnant woman can call, family members can call, and care providers can call and say, hey, I have this woman, she just found out she's 9 weeks pregnant. She uses alcohol, tobacco, she's on an antidepressant, and she's on pain medications. How's that going to shake out for the baby? And we can provide information and help that care provider or that person. And we actually have fact sheets that are in English and Spanish. Okay, if we have time at the end, I could take you to a website that you can access. And it has everything from herbal remedies to alcohol to illicit drugs. It's a great resource, and I can show you how to get there. Okay. All right, so let's talk about fetal development. And again, the disclaimer, I am not an embryologist. So this is just your Joe basic embryology. Okay. When we look at this, okay, what I want to point out is that the red line into yellow is talking about teratogen exposure. Specifically, we're talking about alcohol use. And for alcohol use, know that, you know, when we're talking about exposure to the central nervous system, notice that this is developing the entire pregnancy. It doesn't stop here. And we talked about the brain continuing to develop until around age 25 to 27. So again, one of the main building blocks and one of the earliest organs that forms the central nervous system and the heart as early as 3 weeks. And then this is talking about other parts of development and areas of exposure. We're going to zip through this one really quickly, so hang with me. It gets hung up there. Yeah, you're going to love that. On to this much prettier one. This was actually done by a Dr. Kathy Sulik, who is located at UNC Chapel Hill, and she and her team actually have found a particular type of mouse that has the same gestation as women. So she and her team actually introduce these mice to binge drinking sessions. Lisa and I were discussing at dinner last night. We aren't really sure how that happens. Is there like a little petri dish and they all come up and drink and it's happy hour? Do they inject them? We do not know how that goes. But they are exposed to binge drinking quantities because that's what we're looking at. And what Dr. Sulik has found, and it's just fascinating in that when you look at a mouse embryo and a human embryo, and there's alcohol exposure and then pictures of actually like Gracie and so forth, even the mouse embryo, the facial features are identical to what you would see in Gracie. And so do Google Dr. Kathy Sulik, S-U-L-I-K, and you will be able to access her research. There's been counterparts across the nation. Dr. Natalie Novick-Brown, who is also supporting that research, and other research sites are mimicking that as well. So what we do find is that binge drinking sessions, okay, can cause adverse effects on the developing embryo and fetus. Now, real quick, when we talk about embryonic development, there's two different ways when we talk about the age. There's the age, the gestational age, like the woman feels she's 3 to 4 weeks pregnant. And then there's the age of the embryo. They're very different. The woman's 3 to 4 weeks pregnant is based upon her last known menstrual period. Okay? Whereas the embryo is going to be a little bit younger. So, for a woman who's right about 4 weeks pregnant, okay, and she's just about to miss her first period, the embryo is anywhere from like day 17 to day 22 in age. And what Dr. Sulik has found, and this is human embryology here, what Dr. Sulik has found is if there's a binge drinking session that occurs during this time, not only does it cause damage to the primitive brain, or some people call it the prehistoric, I call it the building blocks of our brain, because our brain develops from the inside out. Damaging that, but at the same time around between day 17 and day 22, the same cells that are moving forward and building the foundation for the brain, the corpus callosum, those cells actually kind of fold in on themselves and back out and develop our facial features. So what she's saying is that if there's exposure surrounding this time, day 17, day 22, oftentimes the individual will present with actual physical facial anomalies. But depending upon how much and the exact timing, they may have partial FAS, or they may not get any of the facial features, depending upon when that binge drinking session or consumption occurred, but that there can be that brain damage, which we may not pick up on for years and years, because eventually it starts presenting with learning disabilities and then possibly behavioral challenges. But anytime there's consumption during the pregnancy, that central nervous system and brain are developing. So again, you know, when I'm talking with clients, I would probably say, you know, if you're building a house and you're laying the foundation and the cement in that foundation, the concrete, and there's cracks in that foundation, do we continue to build the house upon it and expect everything to be okay? No, we know that there will be problems. And that's the same thing about alcohol exposure during pregnancy. When that exposure is happening, that brain is developing the entire pregnancy. And any time where there's alcohol exposure, there can be cracks in that foundation. Little blips on the radar, things that an MRI is not going to pick up, but it's going to present in behavior or a learning disability. So we have to be thinking about those building blocks of the brain. Just to also let you know, this is here what we call the midline of the brain, this little blast of light here and a line here. So this is a profile of it. Here is the posterior, okay, this being the brain, here the spinal column. Also to note that the neural tube closes around day 22. So all women in this room that are of childbearing age, and that's to me 15 to age 44, you need to be on some type of prenatal vitamin or a vitamin that contains folic acid, because the neural tube closes early at day 22, and that's when damage could be done before you even know you're pregnant. So if you're in that age range, you need to be on some type of vitamin with folic acid. To give you a perspective of the size and how finite this is, here the brain, this whole embryo is really about the size of the ear on a dime. So it's almost hard to conceive how early on this damage can be, but it is early on. Question I always get from teenagers: if I drink the night I conceive, will there be damage? Well, if there's been repeated consumption, it's changing us genetically, you know, and we're passing that forward, so sure. But as far as an FASD, no. But once, you know, if there's continued consumption, yes, especially in binge drinking sessions. Okay. So we know, let's truck on down the line. We know that during the early stages of pregnancy that exposure is detrimental. But as the woman continues throughout the pregnancy and she continues to drink, her body tries to metabolize the alcohol, but we already know that women metabolize alcohol a little bit differently than men, and it can be much, much slower. But it goes, you know, into her digestive system, and it goes to the variety of organs in her own body, including her own brain. And then it does cross the placenta. The placenta works very hard to try to filter out anything bad that is coming in. It delivers all good, but also bad does get through. This is an example of my placenta. It's not my placenta, it's my plastic placenta. Mine actually, my placentas are buried in the backyard. I'm kind of a hippie, and it's a Native American practice. You bury your placenta and you plant a tree with it. It becomes your child's talking tree. So to help them manage mental health issues and challenges and teenage angst, they go and they talk to the tree. Okay? My 18-year-old has pretty much beat the hell out of that tree, and but he does spend a lot of time out there. And it also gets them out into nature instead of using other. But anyway, so my house will not sell, though, and the realtor thinks it's because my placentas are buried in the backyard. But anyway, just a little side quirky note about me. So this is a great teaching tool. You get it from Health Ed Co. if you're working with women. And it has bottle caps denoting alcohol use, prescription, IV or injecting drugs, and cigarettes, tobacco. So it will break, so be careful. Pass that around. So what will happen is, let's say the placenta is fully functioning, the woman consumes alcohol, it crosses through the placenta, and it gets to the developing fetus. And the fetus works very hard to try to metabolize it, but the interesting thing is a fetus doesn't have what we as adults have, and that is called alcohol dehydrogenase. It's an enzyme that we have that metabolizes alcohol. Fetus doesn't have it. It happens well after birth and as we develop and grow into adults. Our youth don't even have the fully functioning enzymes that they need to metabolize alcohol. So metabolization doesn't happen. So a majority of the alcohol can and will concentrate in specific organs, the brain being one of them. Then an interesting thing happens in fetal development is that as the fetus is developing, it will actually practice breathing in utero by taking in amniotic fluid. It will also excrete or urinate into the amniotic fluid. It's all normal process. A lot of women will say, oh, my baby has the hiccups. Well, it's really the baby going, hup, hup, and it's taking in that amniotic fluid. What studies are showing that when there's alcohol exposure, the fetus is picking up the alcohol, doesn't metabolize as well, concentrates in the brain, it's processed to their body, they excrete it back out into the amniotic fluid, and guess what they do? They take it back up. It's called a reuptake. So until they can truly get it all processed and it's picked back up by the mother's bloodstream and then carried back out through the umbilical cord and placenta, there's often a prolonged exposure period to that alcohol. So initial studies are showing that the blood alcohol content level of the fetus is often higher than that of the mother's. So that continued exposure throughout pregnancy is very dangerous, because again, the brain is continuing to develop the entire time. Okay? So the prenatal effects of alcohol, we've just talked a little bit about. We know it crosses the placenta. It actually causes cellular death. It kills brain cells in adults. What makes us think it's not going to kill brain cells in a developing embryo or fetus? It does. And what can happen is it can also cause the cells in the brain to not migrate as they should. Almost all cells are coded to become something. Heart, liver, lungs, brain, regions of the brain. Does anybody know what cells are called that don't have a code or don't have a place to go? Anybody know what they're called? You can't answer, Tina. Anybody? What? Someone said it over here. Coenzymes? How about stem cells? But, what do you like, orange, purple, or green? Green? You tried. Very good. There's your brain. Okay. Stem cells. That's why people are so interested in stem cells. Okay. So, what can happen is those regions of the brain don't develop correctly because the cells that are developing the brain are kind of misfunctioning, and they go to the wrong area. So regions of the brain don't develop correctly or at all. The nerve formation is interrupted. We know that the actual neurotransmitters do not function as they should. The synapsing and the connecting doesn't happen because of the reprogramming of those brain cells. And we are often see challenges with molecular adhesion. So that's the actual cellular attachments. And we can go into this at much greater length. But again, the building blocks are damaged from the inside out. Key areas of the brain that we're going to look at, and again, we don't have a lot of time to do all of it, definitely our frontal lobe, the CEO of our brain, is affected. That's responsible for impulse and judgment. But another one that we don't look at as much, but we should, is the corpus callosum. And remember, in the beginning, that's one of the first areas of the brain that's formed, is that corpus callosum. And that's responsible for moving information from the left to the right hemisphere of the brain. And it handles logic and impulse and feelings. Then the cerebellum plays a major role in motor coordination, and here's a big one, in behavior and memory. And when we talk about how FASD presents in individuals, we will find that oftentimes they have challenges with memory and behavior. So here's the cerebellum. And then amygdala, my favorite part of the brain. Primary role is for processing information and memory, but it's also our emotional reactive site. That's where our fight or flight response comes from. So those, and it's part of the limbic system. So some of you may be working with individuals that it seems like their little amygdala is flipped on the entire time. They're in a constant fight or flight, always reactive, always. Okay? So this was a study that was done by Ed Riley in 1994. The damage was so significant they were able to capture it on an MRI, but we do not use MRI in testing or diagnosing because it's very expensive and because the damage can be so microscopic, minuscule, that a normal MRI is not going to pick up on it. But what you see here is A is a normal corpus callosum, no alcohol exposure, and this was of a 14-year-old. But B is of a 12-year-old with what we call a very thin corpus callosum. Do you see that below the arrow and where my green light is? And then C is a 14-year-old with what we call agenesis, or absence of a corpus callosum. Now C is rare. It does happen, but it's rare. And an individual with agenesis would still be able to function somewhat, but they probably would have, they would be probably classified as having an intellectual disability. Okay. But what I want you to look at, if you would for just a second, would be to kind of imagine more of a spectrum. And somewhere between A and C, we might find Bradley, and we definitely can kind of see Gracie. And I don't know if I can do this with the light or not. Sorry about that, guys. But seeing some similarities, I'll keep her in the white right there, with the shape of the head. But I want you to look beyond the structural damage of the head and look at the brain. Are there any other areas that you see that are different than just the corpus callosum? What is it? Cerebellum, absolutely. And the frontal lobe. Yep, in the frontal lobe. What else? And we even see changes in the nasal cavity. And that's also going to present in facial features as well. Okay, so again, this lends itself to that regions of the brain don't develop correctly. So therefore, their function is going to be altered as well. On the left-hand side, this is courtesy of a Dr. Sterling Claren, who is in Canada. They are light years ahead of us in Canada with research and intervention. Tina and I, a good friend of mine here, we want to move to Canada because they do have so many interventions in place. On the left is the normal brain of a 6-week-old baby post-delivery that died, not related to alcohol-related conditions. On the right is the brain of a same-age baby that did die related to alcohol, actually had fetal alcohol syndrome. So we see that the hemispheres of the brain are not symmetrical. We also see that the beautiful rays sulci, the beautiful, beautiful brain and the grooves, not as much here, very flat. And I would even go to say that I see a difference in size, okay? And then also we're missing some gray or white matter, okay? Again, areas of the brain not developing as they should because of that alcohol exposure. So how is this going to present in an individual? Well, cognitively, here's the crazy piece, is that an individual being on the spectrum, their IQ can be in a range from anywhere from 30 to 140, dependent upon exposure, dependent upon the type of damage that occurred. And I also think, depending upon when we might have been able to identify what happened with this individual and what interventions are put in place. Because we do know the early we can identify individuals that maybe were exposed to alcohol prenatally, and the more interventions we can put in place, the better chance that they have of having a more productive life. And Tina, can I out you now?
Yeah.
Okay. Tina and I met in May. She came down to North Carolina. We had a big training on FASD. And she is 2 hours from here and is a parent of a child with an FASD. So I don't want anyone to bombard her after the training, but she has volunteered to answer questions. And she's available if you have other groups that maybe would like to speak with her or have her talk. I know that she can do that. I'm just throwing you out there under the bus. And, but I think it would be great to identify that there are resources and families and individuals in your state that are dealing with this on a daily basis. Okay, so that's the hard part, because you have a parent who may have a child that is somewhere on the spectrum, and so On average, for fetal alcohol syndrome, an IQ may come in around 60. If a child comes in with an IQ around 60, we kind of know what we're doing as far as being able to put interventions in place for them. But what if, and so that's probably Gracie coming in at 60. But Bradley, however, is going to come in with an IQ at 80. My youngest has learning disabilities, not related to alcohol, but he does have learning disabilities, probably genetic, coming down both my side and the dad's side. His IQ in second grade was 80. I had to fight like the dickens to get modifications and interventions for him in the classroom. That's not the teacher's fault. That's just kind of how things are set up. But that's tough because they may not necessarily be presenting with behavioral challenges yet, but they become so frustrated that eventually they might. So and I want you to, if you definitely work with families, to consider how impactful this is and difficult it can be because they can't quite put their finger on what's going on with their child. They may not have a diagnosis of FAS, but the child may be somewhere on the spectrum, and they don't fit into any category, but they're labeled with gazillion different co-occurring diagnoses. Did I summarize that pretty well? That happens a lot. Oh, yeah. So, also, they may have an average IQ, but their adaptive quotient or adaptive functioning may be much lower. So, someone that both Tina and I do follow, a Diane Melvin, who actually is a birth mother of a child who's a grown woman now that has an FASD, made it her life to dedicate to educating individuals about FASD. Her name is Diane Melvin. And Diane Melvin talks a lot about the adaptive quotient and that oftentimes these individuals can be passing school, but they're failing life. They have a hard time following rules or taking a rule from one location and placing it somewhere else. No matter how many times you go over it with them, you write it down, you have them read it back to you, they don't get it. And you're pulling your hair out because you don't understand why they can't understand this. And that has to do with the damage in the brain and the being able to process it. Okay? Also, Ann Streisguth is an actual psychologist that works with individuals that have an FASD. This study was done in 1996. She too supports the work of Diane and vice versa. And definitely we have come to understand that some of the primary disabilities that will present with individuals that were exposed to alcohol prenatally would be intellectual disabilities, which for most of you know that has replaced the terminology, or the term mental retardation. So we use intellectual disabilities. They may present with attention deficits, sensory processing disorder. How many of you have ever gone to a training on sensory processing disorder? Raise your hand. Okay. If you offer anything else here, if you can, or if you can get to one, if you work with youth, children, families, please become educated on sensory processing disorders because many individuals that have an FASD present with that. And the thing about sensory processing disorders is a lot of the help can be done by changing the environment in which the individual is in. It's huge. Yes, ma'am. Sensory processing is I'll give you an example. My child that I talked about that has a learning disability, born prematurely, okay, 34 weeks. He was C-sectioned, intubated, and so had a lot going on at birth, was in NICU, a lot of invasive procedures, and based upon probably whatever was happening genetically in the development of his brain, combined with all that overstimulation surrounding birth, he was diagnosed with sensory processing. So a lot of things happened with him in that the sound of that, whatever that noise is over there that keeps shutting on and off, would drive him crazy. He would not be able to focus on anything else in this classroom or this room setting because he was hearing this, or the buzz of any fluorescent light bulbs. The tags in the back of his or her shirt irritates them. Their waistband, the left shoe is too tight. All these different symptoms. There are those of us in this room that have sensory processing. Some of you like yogurt and the texture. Some of you can't do it. Some of you can do oatmeal but can't do cream of wheat. You have quick gag reflexes. These are all sensory. And our central nervous system helps us stay aligned so we can process whatever's coming in our environment. When there's a disorder or something not connecting as it should, we get irritated easily. And those irritations, if there's a combination of them, can affect how we learn and will present in our behavior and how we act out. Okay, that's kind of the short of it. Yes?
Just like kids can be really oversensitive to those kind of
They can
things,
be under.
they can be very undersensitive.
Mhm.
For my son in particular, he has no pain reaction whatsoever. He broke his nose, and the only reason I knew it was because when he went running by me, it was spreading across his face like a grapefruit. Never cried, never told me anything hurt.
Yep. And those kids also might be the ones that when you're playing with them out on the playground, they run and they slam into you as hard as they possibly can and can knock you down, and you're like, use the words gentle, no, and you use all the standard things that you as early childhood, and they don't get it because if they don't know they've touched you. They have to actually physically be into you. So, but there's interventions that you can do to help them become more aware, to manage their central nervous system, to manage those feelings. But it's tough when they're undersensitive because they may stand in the shower with scalding hot and burn themselves and they never feel it. Okay? Whole nother class could be done on sensory processing disorder. Please access, I know your state has it. I can help you try to find it if you need it, but it's definitely something you should learn about. So, possible challenges that we would see with the executive functioning, because remember that CEO, and I'm sure Tina would attest to this, oftentimes parents of children with an FASD say, I have to be my child's external brain, because they just can't seem to process. So what we do find is a great intervention is if we do identify someone, whether they be a child or even in adulthood, that has an FASD, pairing them with a buddy helps tremendously because they need that external support to help guide them, to remind them, those types of things. So oftentimes they'll present with challenges in reading, math, problems with money. Also, I'd like to say telling time oftentimes can be very difficult. Understanding abstract concepts. Our whole world is abstract. Everything from commercials to how we talk with one another. Okay? Even simple things like a parent may say, oh my gosh, if you don't turn that TV down, I'm going to lose my mind. They do not understand what lose my mind is. Or how many of you, probably women in this room, have ever read Amelia Bedelia? You know who that is? Amelia Bedelia was very, very concrete. So if I had said to Amelia, please draw the blinds. Okay? She wouldn't have known to walk over and draw the blind. She would have got a piece of paper out and would draw the blind. So for the remainder of the day, once you leave here, I want you to start paying attention to how much abstract language you are involved in between your friends, your coworkers, and your family. And you will be amazed. And if you try to inject a person who doesn't get abstract conversation, how are they functioning? They're missing every other piece of what we're trying to communicate with them. I'll even say the Miranda rights. You have the right to remain silent. And when I work with juvenile justice and criminal justice folks, I have them read it. It is one of the most abstract documents in the United States. And when we have individuals that have an FASD and they're read the rights, they don't understand any of it. But they will agree to all of it because they're also pleasers, because they so want to connect with other people that they will agree to anything that you say, even though they don't understand it. Attention deficits, again, the learning from experience. Many school teachers will say, I don't understand. Jimmy is awesome and he gets it. He gets it in the classroom, this one particular rule, keeping their hands to themselves. But the minute we go into the cafeteria, he's touching everyone and anyone. It's because he got that rule in that setting, in that surrounding. He doesn't know how to take the rule and impart it into another piece of the school. Okay? And then the processing information. Diane Melvin will often say they're 30-second individuals in a 10-second world. You think about how we are nowadays. If our laptop doesn't boot up quickly or as fast as our phone, or our phone isn't as fast as our laptop, we get frustrated. If somebody's taking too long in front of us in the grocery store line, we're irritated. We've just all jumped on that bandwagon, unfortunately. Well, these individuals process much more slowly, but we're still expecting them to keep up with everybody else. So when you're working with individuals that may have an FASD, you need to slow things down and remember the processing speed is much slower. So here's the kicker. Here's what I want you to take away. We still have some time, so nobody start packing up yet. What if we viewed the damage done by prenatal alcohol exposure to the brain as actual physical condition, an actual physical disability? Okay? I see a couple people in the back that have glasses on. Is anybody nearsighted? Okay. Sir with a checkered shirt, do you mind playing a game with me? Take off your glasses, please. Okay, you're in my classroom, okay? And you've just removed your aid, right? I don't know that. I want you to read the first bulleted point, please. What's your name? Walt? Well, why not Walt? It's pretty clear. You can read it, can't you? Okay? Just try. Just try to read it. Try hard. Yes, I'd like you to try as hard as you can. Okay, Walt. I know, Walt, but your body behavior is showing to me that maybe that you don't care and you're just not trying hard enough. Okay, well, Walt, if you couldn't see that, why didn't you come to me and tell me that you needed to move to the front of the class? Okay, thank you, Walt. Hand for Walt. Walt, are you green, purple, or orange? Purple. Watch out, folks. Oh! I am so glad. I'm not going to quit my day job, that's for sure. Sorry about that. Okay. Okay. We make accommodations for visual impairment, physical impairment, speech impairments. But we don't when it's the brain because we can't see it. If we all wore our brains out like this or on our name tag or whatever, we would live in a different world and we would see that it is about brain diversity. So what I'm encouraging you to do is to actually think that maybe the exposure to alcohol prenatally, and we could even go on to pair it with other teratogens causing damage to the brain. Then, just for kicks and giggles, let's just throw in multiple placements if we're talking about a child. Or let's throw in some trauma, abuse, neglect. Years of this, and they now are presenting as adults. We have all these expectations of people. But if we're talking about an invisible, physical brain-based disability, we have got to start thinking about accommodations and modifications. It's critical. And we would have never done that to Walt in a classroom if we had known, that he was visually impaired. But we do it every day to individuals that are impaired cognitively. So I want you to think about that. And we already know all this, that alcohol kills brain cells and so forth. But here's the kicker, that the behaviors that we see in the individuals we work with, whether they be children, teens, or adults, we get hung up on the behaviors. And the behavior is really just the symptom of the problem, which is the brain damage. Okay? So how does this present across the lifespan? Real quick, we're going to blow through this. You will be getting copies. Infancy to preschool, small height, weight, poor sleep patterns, difficult to soothe, poor feeding, bonding problems, and stranger anxiety. On into preschool, temper tantrums, trouble learning rules, they shut down easily, okay? They're overly sensitive or under-responsive, just like Tina was saying. Then we go on and we see these primary disabilities, memory problems, trouble processing information, delays in social and emotional development, that executive functioning deficits, they need that external brain. They have impulsivity, again, difficulty with abstract concepts, lower IQ, and then that presents with behavioral problems. When we look at teenagers, and these are pretty typical looking teenagers, and these are pretty typical teenage anyway, whether or not they had prenatal alcohol exposure. But they're heightened in the teenage years, even more so if they have a brain-based disability like an FASD. Challenge of identifying individuals in FASD? Yeah. This sweet little fella was diagnosed with fetal alcohol syndrome when he was around age 8. Here he is in high school, and here he is as an adult. If you had seen him as a high school student or as an adult, would you have thought that he had an invisible brain-based disability due to alcohol exposure? No. We don't always know. So the challenges going from adolescence to adulthood, less obvious features, poor judgment and impulsivity, they're defiant and uncooperative. They can't predict consequences. They seem to repeat the same behavior over and over again. They do not have any stranger danger. They're kind of fearless. They tend to get paired with the bad kids or people that engage in bad behavior because they're accepted. They often themselves will go on to use alcohol and drugs. And this population is at the highest risk for probation violations, missed court appearances, and false confessions, okay, because the impairment of their cognitive ability. So, again, if you're working with adults, know that they may not keep appointments. When I said, let's take a quick break and come back, you guys knew how to gauge that. But an individual in the FASD doesn't really know what 5 minutes feels like. So oftentimes they'll be late for an appointment, come back 30 minutes later, 2 hours later, and you're livid because they missed their appointment. But to them, they just didn't get it. Or maybe they don't know how to tell time. Maybe they can tell time by the clock on this wall, but they don't know how to tell with a digital clock, or vice versa. That one has numbers. Some clocks don't have numbers, but we take all that for granted. Okay? Let's see, what else? Co-occurring disorders. You have a handout on the table that talks about this. Developmental gaps. This is huge. If you're working with youth, please keep in mind, this is from Diane Melbourne, that oftentimes chronologically they'll be 5, but developmentally it'll be like they're 2. So really the modifications in working with that individual needs to be focused on the age 2, not with their chronological age. But that's not what we do in the school system. Okay? A big one, 13, they're headed right into adolescence. And puberty is right on task, right on target. So Bradley's going to be 13 and he's going to be presenting with all those symptoms that a normal teenager would going through puberty. But developmentally he's really 8. So he's drawn to younger children. He plays with younger toys. He's not like all the other kids his age. And we have a situation in North Carolina where we have a young family that has a child who has an FASD that is 13. And unfortunately, he acted out sexually on another child in Sunday school because he was in the younger Sunday school class because that's who he connects with. So what we've been trying to figure out, was that true deviant behavior, or was he just responding to normal urges of a 13-year-old, and if he'd been paired with another 13-year-old, it wouldn't have happened, or it wouldn't have rolled out that way. So this can be very problematic for those of us working with families. Bradley grows up and he's 18. What I want you to keep in mind is that chronologically he's 18, but his expressive language is 23 years. His social maturity is around 12. His math skills 8, but here's the kicker. You're going to slide that piece of paper across and say, okay, I want you, Bradley, to read all these requirements for you to be able to get your kids back, or your probation, or completing your IOP, whatever it may be. They're going to read through it. Bradley's going to be able to decode it because decoding is about 14 years old. He can read it. He'll parrot it back to you, but he doesn't understand it because his comprehension is sitting around 8, 9 years of age. So this means we have to even look at the materials that we're giving individuals. And even though they can parrot it back to us, they may not be getting it. So we have to take longer and work with them. Okay, so the strengths: loving, kind, sweet, creative. Oftentimes they can be artistically inclined, often like musical instruments, can be very hardworking. And if you find something that they're doing really, really well, they will work like the dickens to please you and do great things for you. They're highly verbal, so oftentimes they can talk the talk, but they can't walk the walk. That's something you need to look for. I know we're a little bit after 11, but we started a tad late. If you can hang with me, I can hang with you. We good for about 5 more minutes? Okay. All right. So the importance of protective factors. If we can get these put in place and early identification happens, it can help improve their outcome. Are we realistic with families that Bradley may not ever have a typical or what we call normal presenting life? But they can still have a good life. We just have to reevaluate what that is. And that can be very hard for families working through that once they figure this out. So they're going to need a lot of support. Early diagnosis before age 6 would be ideal. Early intervention, stable, nurturing home environment, absence of exposure to violence. That's not only domestic violence, but that's also TV and video games. Because if they have processing issues, they don't process it the same. And hopefully few changes in caretaker placement, getting them definitely into social and educational services. And I bet many of you are already on the interdisciplinary team working with children or individuals. And that is important because the families and those individuals are going to need that collective support. If we don't get those collective protective factors in place, what can happen are these secondary disabilities. This study was done by Ann Streiskooth in 1996. I've heard that she is redoing the study. The initial numbers are coming out about the same. 94% do tend to have some type of mental health issue. Remember, we talked about it being in the DSM-5, kind of in the appendix, so we're seeing that. Disrupted school experience, trouble with the law. We do feel that about 50% of those that are incarcerated, in jail, or in some type of treatment program probably have an FASD, but they were never identified. So they may not necessarily need to be in jail. They may need to be in treatment or in some other program. Alcohol and drug problems, 35% go on to have their own alcohol drug use problems because that's a method of acceptance with their peers that they maybe never had. So if we're talking about women and they're consuming alcohol and they have an FASD, that increases their chances of having a child with an FASD. And we already have started to see second and third generation FASD in North Carolina. Not because it's genetic, but because they struggle with their own alcohol problems. 83% dependent living, and that's very tough because families are normally going to be planning an empty nest syndrome type situation, and that's not going to happen because they never leave home or they are in some type of group or home placement. Okay? Employment problems as well because they have a hard time showing up on time, following rules, and understanding how our world works. So your role as a behavioral health clinician or working with individuals is the identification and putting interventions in place. Because if you help identify this and get interventions in place, that's going to decrease the frustration not only for the individual, but for you, for the families, and the community. Okay? Helping focus on what the individual can do and not focus on what they can't do. Because in our society, we look at what doesn't work. We have to start looking at what they can do and build on those strengths. Okay? And also to learn that this isn't because they don't want to do something, because I was picking on Walt. I'm like, no, you just don't want to do it. That's probably not the case. It's not that he didn't want to, it's that he can't. But we tend to go with, they don't want to. So we have to change our thinking. Okay, we're close, I know. And this will also help prevent future births of children with an FASD. Attitude is half of the battle. Simplifying the lifestyle, using concrete, simple language, and making sure that we keep them on a healthy diet, minimal sugar, okay, caffeine, those types of things. And as family members and as support persons, you kind of have to become a behavior detective and evaluate the environment to see if there are triggers that are causing them to be agitated and not being able to function in their particular setting. So I encourage you to look through a different lens, that this could be an invisible brain-based disability, a true physical disability, to look at their developmental age, not the chronological age, take into consideration that no protective factors ever occurred, especially if you're dealing with adults, that they could have an overlapping diagnosis, or they were never diagnosed or misdiagnosed, and that there's a history of substance use and trauma in their family, and also for themselves. And I'll let you read this on your own, but I think this is huge. Dan Dabowski, awesome, awesome man that works in the field of FASD, and his son Bill died in his 30s. Bill had an FASD, got hit by a car because Bill couldn't take that rule and move it to new locations. It's very sad. But Ross Greene sums it up. Our interpretation of the behavior will guide the intervention, and that's key. So if we think they're bad, we're going to treat them bad. If we think that they don't care and that they can't or that they won't, that's how we're going to treat them. And we're going to set up interventions that way. So we have to have a paradigm shift. Opportunities of prevention, you just participated in the biggest one, universal education, taking some of this information and sharing it with others, having me come back, have Tina come speak, research and get more information. If you work with high-risk women, making sure that they understand what FASD is, maybe screening to see if they themselves have an FASD, and making sure that they actively use birth control in prevention of subsequent pregnancies. What are we up against? Thank you, Budweiser. Say no to drugs, that way you'll have more time to drink. There's a misperception that alcohol is not a drug, but it in fact is. It's the most widely used and accessible and dangerous drug, especially in causing prenatal alcohol exposure and causing FASD. So our clear message, this says, I'm a mother-to-be, no drinks for me. Just remember when working with women that blaming is counterproductive, that all women need education, motivation, and some will need additional supports, and some are going to need referral to treatment. Okay? That early identification and diagnosis of FASD is crucial, and that FASDs are 100% preventable. If you do not consume alcohol during pregnancy, you're not going to have a child with an FASD. These are a host of resources for you. If you click on these individually when you get the electronic version, it'll take you to these links. NoFast is huge. The FASD Center for Excellence is great. Here's NoFast, which is 2.5 hours from you here. CDC sites. These are information for clinicians on how to screen women. Facets is Diane Melvin, the lady I mentioned that is really behind the whole neurobehavioral brain-based disability. She's excellent. And then I told you early on about the pediatric toolkit. This is a link that will take you there. Okay? So the last slide is my favorite quote by Benjamin Franklin, an ounce of prevention is worth a pound of cure. And that's why you're here today, is to learn more information about preventing this disorder. So I thank you for your time and your patience, and namaste. So.